we found it. So this is the case presentation focused on spindle cell lesion. The first case, well, you will see. So we start with the first case. All these cases, I think, have a core biopsy first, then an excision. And I'm going to quiz you. What is this, in your opinion? Core biopsy, we're in the breast, right? Let's see, here the proliferation is composed of fascicles that are entrapping some benign benign glandular elements. Here is an area where we have only a spindle cell component, fascicles, spindling around there is some heterogeneity here. The lesion seems to end down here, right? A little bit more fibrous at the periphery, here a little bit more cellular, and it's circumscribed. It appears to be circumscribed in this area. And even the focus before, I think here, yeah, is the same focus. It looks circumscribed. Here, I'll give you more views. So what would you do in a case like this? I'll now quiz people. What would you do any stain?
The stain?
Cytokeratin,
Yeah?
P63.
Excellent. So you're thinking about a metaplastic spindle
I would be afraid of this. I would like to rule it out.
Yeah. The spindle cells, do you think they have atypia?
No.
No, good.
But
at least we all agree. But that is a differential diagnosis. Fibromatosis.
Fibroid metastasis, like, yes.
So I can tell you all the keratins were done and none was positive. P63 was also negative. This case came from another institution. I don't have the stains, but they reported them as negative. And I believe it. Anything else people would do? Anything else? Well, the name fibromatosis-like metaplastic spindle cell carcinoma has the other differential diagnosis in the name itself, fibromatosis. So what would be a good marker for fibromatosis? Beta-catenin, very good. So that one I have, and is right here. So what do you think about this? Beta-catenin is, in myofibroblasts will be cytoplasmic, but in fibromatosis, there is nuclear staining, right? Do you think this is good nuclear staining? Yes, it looks pretty positive, nice nuclear staining. We're all set, fibromatosis. Is it fibromatosis? Consensus?
No. For me, no, it's not true.
Probably not, the way I'm asking it, right? But it was signed out as fibromatosis, and honestly, CD34 was negative. So I think it was negative in this case, and it was signed out as fibromatosis.
Maybe also glioblastoma.
What? Myofibroblastoma, no, yeah, that was not done, but I can tell you it's not. The main differential in this case, I think, is with fibromatosis. It was called fibromatosis, and then it was excised. Here is the excision. Do you still think it's fibromatosis based on this low power view? Have you ever seen a case of fibromatosis that is so nicely circumscribed? This was a circumscribed ovoid mass, both on imaging and at excision. And it has, a sharp edge, nodular, has variable cellularity. And here are the same cells, the same fascicles we found in the core biopsy. An area like this is the area that was sampled. And, there is a spindle cell proliferation. There is increased stromal cellularity, I would say moderate. Would people agree? Moderate cellularity with this, okay? and still not too atypical in terms of nuclear features, right? I can tell you, I don't have mitosis. It's very hard to find mitosis with this system, but the mitotic activity was less than 6 per 10 high power field. Here, there are some areas a little bit more fibrous, and based on these findings, this case was heterogeneous cellularity, circumscribed border, mild to moderate cellularity. This was called benign phylloides tumor. Notice, like in these areas, there is a little bit of variation in the cellularity, very, a little bit less cellular in some areas and a little bit more myxoid stroma. And here there is increased cellularity, but also there is a lot of lymphocytes. It makes it a little difficult to assess the true cellularity, but maybe it's a little bit higher. And this another area. So the story continues because the patient had an excision, then recurred, and this is from the, I think, the mastectomy specimen, or is the intermediate excision. Look how the tumor looks now. It doesn't look fibromatosis like anymore. It didn't look already in the excision, but it's clearly infiltrative. There is no epithelium that we can see. Oh, I'm reading it, and I wrote that here. There is no epithelium, and it's clearly infiltrative. We find, these adipocytes really embedded in the tumor. This is not a liposarcoma-like component because they look really, really very bland. This is peripheral infiltration along a broad front. The cells, though, are still very bland. And they have, low mitotic activity. I don't know if that's a mitosis, probably not. The cellularity is still moderate at most. It doesn't look like a marked stromal cellularity. Now, this case, would this be stromal overgrowth? Yes, there is absolutely no epithelial component, still nodular and circumscribed. How would you call this? Less than 6 mitosis per 10 high power field. Would you do any stains? Well, I would be curious to know, is it still positive for beta-catenin? And if I manage to advance, here is beta-catenin, and it is still positive. Actually, nuclear positivity for beta-catenin is quite strong in this case, even better than the initial core biopsy. Huh? Even more convincing, yes. And again, this case generated a little bit of, discussion because it was, we have now the criteria to diagnose malignant phylloides tumor. This one qualifies in terms of stromal overgrowth, but it doesn't really have all the criteria to call it malignant because the stromal cellularity is moderate at most, the nuclear atypia moderate at most, and the mitotic activity counted repeatedly was 6 mitosis in 10 high power fields. So, and it's beta-catenin positive. The stroma is very myxoid. So I think there is something going on with these cases. It remains CD34 negative. Typically, CD34 is positive in fibroepithelial lesion. Different opinions were obtained also from, the patient sought consultation elsewhere. We eventually called it at least borderline. And I am showing you this case because I was puzzled by this case. I remain puzzled by this case. I think I would have fallen for the diagnosis of fibromatosis in the core biopsy myself. It looked such a perfect fibromatosis, so positive for beta-catenin, while beta-catenin can be positive also in phylloides tumor, especially in benign phylloides tumor, 94% of cases, but also in phylloides tumor as well as in metaplastic carcinomas. So this was the diagnosis that I rendered for the core biopsy. I initially was called fibromatosis. So when I received the case, I already knew that the patient had a benign phylloides tumor in the excision. So that's how I worded the diagnosis of the core. The mastectomy came at our institution directly. The patient had surgery at our center, and I struggled with this case. And actually, we did all kinds of molecular studies that I have inserted here in one of these notes. We did Archer that showed the no gene fusion diagnostic of sarcoma, because I showed this case also to my soft tissue pathology colleagues, and they were considering, you know, the possibility of a soft tissue sarcoma. We did NGS and didn't find any MET12 exon 2 mutation. Sorry, we did find it. And there was also the third promoter mutation, which supported that this was indeed a phylloides tumor. So molecular evidence in these cases was very strong, including the presence of the third promoter mutation that correlates with worse, more aggressive behavior. But the diagnostic features were not definitely malignant. I also spoke, this case went to an outside consultant on request of the patient, and the consultant called me, and we discussed the case. We were both very puzzled by this case. So maybe there is something, and this patient recurred twice with this myxoid stromal quality. So that's why I wanted to show this case. To correlate with what I told you before, there is probably something going on with these tumors that have a myxoid, phylloides, fibroepithelial lesions with myxoid stroma that needs to be better understood, and they remain beta-catenin positive. The next, oh yeah, here is, you know, a mention of what I told you before, how phylloides tumor with this myxoid stroma can have at least local recurrence. Again, this patient recurred twice. Here is another case, another core biopsy. I think I may have two core biopsies with the same diagnosis in these. We have another spindle cell lesion, right? That seems to be circumscribed, but let's see. Does it look really entirely circumscribed? No, it seems to be infiltrating the fat. I often describe this pattern of infiltration as fat necrosis, like it reminds me of fat necrosis. I don't know. So when I see a spindle cell lesion that looks like as fat necrosis at the periphery, I think about this entity. So here is one area, and here is another area. What do you think about this? There is, you know, malignancy here, obvious malignancy. No, the cells look spindled, right? Once again, they're arranged, you know, it's striking though to have this very fibrous area and this area, this a little bit more cellular, right? There is a contrast here, right? And the cells look relatively bland overall. Anything else we can say about these cells? They look like myofibroblasts. Do you believe they're myofibroblasts? They could be if they're cytokeratin negative. Here is another area where also they seem to be lining up one after another. You know, unusual for myofibroblasts to have this linear arrangement, kind of, they seem to be going one after another. And this is another case. I have no immunostains for the previous case, same entity. What do you think about this one? Looks more cellular than the one before. Good. There is a benign glandular element, so we're definitely in the breast. I always look if there is benign breast parenchyma or a glandular element. Sometimes a core biopsy is done of a mass, they say breast mass. It turns out it's absolutely unrelated to the mass. It's a chest wall mass and has nothing to do with the breast. So it's helpful. If I know it's in the breast, then it helps with the differential diagnosis. So here we have a scattering of inflammatory cells here and there, right? And again, these fascicles of cells are these long sweeping fascicles or short, narrow fascicles. Sorry?
Chemistry for
Immunohistochemistry, what would you do?
ALK.
ALK. ALK, I don't have ALK in this case. You're thinking about myofibroblastic.
Inflammatory
No,
myofibrotic
it's
tumor.
not. It's not that. I have other immunohistochemistry. Those are quite unusual in the breast. You may be coming from the soft tissue tumor world, yeah, I don't have that immunohistochemistry. But I have other immuno. Here are the same spindly looking cells that seem to have a little bit more cytoplasm and seem to line up. Let's see if I have other areas. Here is again the peripheral infiltration into the fat with suggestion of areas that almost look like fat necrosis. Here is a higher cellularity, more inflammatory cells, but not as many. And it's not uncommon to find in this lesion an inflammatory infiltrate that is distributed throughout the tumor. And here is a more irregular, the fascicles are more irregular. The spindle cells are really acquiring more cytoplasm and lining up in almost like forming, this could be a vessel, but in some areas, they're reminiscent of capillary vessels. This is a real vessel, but what about this stuff? So any differential diagnosis, any stains people would do? Keratin, always in the breast, you start with keratin. These are epithelioid clusters. I have P63 actually, and P63 is positive. Helpful? Yes, so you're thinking about the same differential we had for the initial core biopsy before. Fibromatosis versus fibromatosis-like metaplastic carcinoma. Fibromatosis against it was the fascicles, very short and irregularly arranged, no longer sweeping fascicles. And the epithelioid clusters, the cells with more cytoplasm. P63 is positive. What else? What other stains will be positive in this tumor? Other keratins. Here is an example of 34B12. Oh, actually, no, this is beta-catenin. So what about beta-catenin? It looks somewhat nuclear, right? In some of these cells, it could be nuclear. Does it change your diagnosis if you have P63 positivity? No. Beta-catenin is in the breast is dangerous because it doesn't have nuclear staining only in fibromatosis, but also in phylloides tumor, as we just saw, and in metaplastic carcinomas of all kind, including the possibility of metaplastic fibromatosis-like spindle cell carcinoma. So there it is. And here is another area where there is unequivocal nuclear staining for beta-catenin. Here is less so, but still some nuclear positivity. And then I like very much doing basal cytokeratins in these CK56, CK14. I think this is 34B12. And this pattern to me is absolutely diagnostic of fibromatosis-like metaplastic carcinoma. These short fascicles of short linear arrays of spindle cells. These are the same spindle cells I mentioned before, lining up one after another. That is a characteristic pattern. And sometimes you see them even at the periphery. Here is very cellular, for example, very positive. These are beautiful tumors because they always stain a lot for cytokeratin. So you just have to do the right cytokeratin. And so this is a fibromatosis-like metaplastic carcinoma. I have a few slides for this. These are the diagnostic criteria. 95% or more of the tumor has to be composed of spindle cells with the low-grade atypia. If you have epithelium, should be low-grade, no more than 5% of the tumor mass. And the diagnosis really rests on morphology, but also demonstrating positivity for cytokeratin or finding DCIS or an invasive and other invasive epithelial component. These tumors can sometimes occur in association with sclerosing lesion. You can see them next to a papilloma, nipple duct adenoma, or an adenomyoepithelioma. And here is a case, sometimes they're very, 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 very bland with this central amorphous nodule. And then the tumor is all in this peripheral infiltration right here, and can be very difficult to detect. I don't know if I have immunostains for this case. Some cases can mimic inflammatory pseudotumor because the tumor infiltrating lymphocytes are often present, in contrast to fibromatosis, where in general they're more peripheral. And then low-grade atypia, hyperchromasia, very focal, and we have mitotic activity that can be found, but rare. And then a very important feature is that the fascicles of this tumor are short and haphazardly arranged. And then in some areas, the cells have a little bit more cytoplasm. They become more epithelioid, even though they are epithelial in origin. We refer to these as epithelioid clusters, and they line up one after another. They almost look like capillary vessels, but they're not capillaries. They're really, these tracts of cells that proliferate. If you use the right panel of epithelial markers, basal cytokeratins, P63, I always do 34B12, CK56, and CK14. In this paper, they use MNF116, saying it's the best. Now, after I read this paper, we tried in our lab. It just doesn't work for us. So there are always various, you have to figure out what works best in your lab. So I still do it, but most of the time it's not very helpful. In my experience, these are always triple negative. And here is a case that just to demonstrate the point how the keratin is important. This was a core biopsy with a similar findings. They had done CK7 and it was negative. It didn't stain the spindles, the carcinoma cells. So they rendered the diagnosis of fat necrosis because many times at the periphery it looks like fat necrosis. The tumor persisted, was biopsied a year later, and that's how it looked on the right. At that point, the right immunostains were done, and it was clearly cytokeratin positive, P63, CK7, the pattern I just described. And actually, when I pulled this case, I looked at the patient, I found out that a year later, she also developed lung metastasis. Very unlucky lady. I don't know what's going on with this case, but these tumors, they are regarded as low grade. I know in Europe, they're very much considered low grade, but they're not, they're still carcinomas, they're still metaplastic, they are low grade up to a point compared to the typical spindle cell carcinoma. Metaplastic spindle cell carcinoma are very high grade, but these are not indolent either. And this is a table that compares the study and looked at the local recurrence in the two largest series published to date. At Vanderbilt, they called these tumors initially fibromatosis, and many of them recurred. But then at MD Anderson, they had properly diagnosed them as carcinomas. They treated them with radiation therapy or mastectomy. Nonetheless, 2 patients developed lung mets and died of disease. And there are other cases where patients develop lung metastasis. Lung metastasis is the most common site. And here is a brief summary. These tumors can recur locally. In the US, in general, we give adjuvant radiotherapy and chemotherapy, at least at our institution. What do you do? No? Radiation, I'm pretty sure, but chemo is more debated. But they're triple negative, so, but in Europe, I believe that there is more hesitancy in giving chemotherapy, and they may just radiate. Still, I think patient age matters. These are tumors that tend to occur in older age. But they can develop distant mets with lung mets, as I mentioned before. So this is another case that looks just like the two I showed you before. What do you think about this one? Well, let's look at it more closely. Another spindle cell lesion, very bland spindle cells. So what about the fascicles? Are these long and sweeping? I guess so. I wrote it in my note. And this, you know, there is a fascicle that really occupies the whole cross section of this core. And many fascicles are very long. You know, this here there is more spindling at the periphery. The clusters of inflammatory cells are more peripheral. And actually, typically, it is said that in the previous entity, there is inflammation all throughout. And in this entity, the inflammation is clustered at the periphery. The best way to assess that is in the core biopsy, because if you look at the excision, the inflammation could be diffused because of the prior biopsy. So in this case, tumor previously, you know, a naive tumor that has beautiful inflammatory cells at the periphery. And again, the spindle cells, there are also many, prominent vascularity. These tumors tend to have multiple, you know, scattered, very conspicuous vasculature. And I don't know if I say that in another area. Here is, it doesn't have the same fat necrosis kind of look at the periphery that we saw before, somewhat more compact with these long tongues. Regarding the vascularity, I'll go back to that probably later. So what's your diagnosis for this case? What do you think? Would you do stains? Yeah, well, it's outside the lesion. We are in the breast. It's not in the lesion.
I was thinking in solitary fibrous tumor.
A solitary fibrous tumor.
And
I
thinking as
do
that 6,
not,
but
I may show you a solitary fibrous tumor if you want. I have one case as a slide. But, you know, fibromatosis would be the first differential diagnosis. It has this stellate appearance with these long tongues, the sweeping, long sweeping fascicles. When you see that, you have to think about that. The myofibroblasts are bland. So beta-catenin would be helpful. And of course, if you do beta-catenin in the breast, you always have to include, you know, the keratins, because fibromatosis has the differential diagnosis in the breast of fibromatosis like metaplastic carcinoma. So you always have to do that differential. Sometimes if I feel it's fibromatosis, I would, I do cytokeratin just to be 100% sure. Age of the patient in general is helpful. Fibromatosis tends to occur in women of reproductive age, you know, premenopausal women, let's put it this way. This is another core. Same, I think it's the same case. I want to point out the prominent vascularity that is with the, you know, the nuclei of these cells are much darker than the nuclei of the tumor cells. And that is a feature that, you know, my soft tissue pathologist colleagues tell me is very, you know, reliable. Well, it's a clue to the diagnosis in the right context and supports a fibromatosis.
I have a question about
Yes.
erythrocytes, which you
Yeah.
see many erythrocytes. One thought I had was about the fasciitis.
Nodular fasciitis, yeah.
So
Nodular
you have not
fasciitis,
really fitting with the fascicle,
you know,
but
erythrocytes, extravasated erythrocytes are not that specific for any diagnosis. You can find them in this case, fibromatosis, in many spindle cell lesions. They are much more prominent if you have nodular fasciitis, but you know, you need to have the right morphology. This one does not have the the, delicate myxoid looking stellate stroma and the stellate cells typical of nodular fasciitis. In general, nodular fasciitis is uncommon in the breast. It can occur in the breast, but it's more, sometimes it's a more superficial lesion in the subcutaneous tissue that feels like it's in the breast because it's right on the chest wall overlying the breast, right in the subcutaneous tissue. And it tends to be smaller. And yeah, I think nodular fasciitis, the diagnosis of nodular fasciitis definitively can be rendered on core biopsy if you can do molecular testing, right? And find this USP6, there is a specific molecular alteration. Anyone expert in soft tissue pathology here? But the USP6 alteration, gene alteration is characteristic of nodular fasciitis. So now we do, I believe, fish for that. So if we suspect a nodular fasciitis, we confirm the diagnosis with fish. And then the patient is watched. They don't take it out. They watch it. And because this is a tumor that regresses spontaneously. So they don't even take it out, they watch, and if it regresses, they leave, they do nothing. If it stays there, let's say 6 months later or grows, then they will take it out. But that's our approach right now for nodular fasciitis. Suspect the diagnosis with the typical stellate, tissue culture kind of look with myxoid stroma. Do the molecular. If the molecular confirms the diagnosis, take it, watch. If a molecular does not confirm the diagnosis, you can still watch it, and the image, with the good imaging and clinical follow-up, and then take it out if it changes, if the clinical characteristic changes. In the meantime, I found a focus where there is some epithelium right here, probably entrapped in the lesion. I just saw it. So this is a case of fibromatosis. This is the excision, this more discrete nodular spindle cell proliferation in this case, sorry. And it's positive for beta-catenin, I think, nice staining, negative for cytokeratins. So these are three entities that with some overlap, even though they look different, especially on imaging. And the first case for me was a surprising case. I have additional, any more questions about these cases? No? Very interesting thing. I actually may have some slides. We generally do not. I just remember, I have slides. This is primary, we call it primary if it is in the breast. So you need to find it in breast tissue, typically reproductive age, trauma, prior surgery, implants can cause that. It's probably there is a component of trauma that stimulates the growth. It's a palpable mass on incidental finding on imaging, this broad sweeping fascicle, bland cytology, rare mitosis. The tumor border is more sharply demarcated or may have slightly infiltration. And typically that's where you find the inflammation, or you find it around the blood vessels within the tumor. And then the staining positive for nuclear catenin, beta-catenin, CD34 is negative, and cytokeratins and ER are negative, loci 67. Can occur also in the context of adenomatous polyposis and Gardner syndrome. So some young women may have that. And this is what I told you already, that the nuclear beta-catenin has been reported in 23% of metaplastic carcinoma, 94% of benign phylloides tumor that will generally be CD34 positive, while fibromatosis is not. And then even in 60% of the malignant phylloides, that can be positive or negative for CD34. And so you need the core biopsy is accurate as long as you have the appropriate morphology, the staining. CD34 is negative, and in this case, I think it was negative. And it was also negative for all the epithelial markers that we need to rule out metaplastic carcinoma. There are sometimes, you know, the mutation in the beta-catenin gene can also be used for diagnostic purpose if there is a, you know, a challenge. Here is another case with some extravasated red blood cells. It's benign, locally aggressive, no mets. In the past, we used to excise all these lesions. And, you know, 30% of them would recur. However, now surgical excision, again, at least at our institution, I know there are some guidelines also from France. Surgical excision is done in symptomatic cases that are function limiting, and no re-excision if the margins are positive. So because re-excision is in itself a trauma that can cause regrowth of the tumor. So let's just re-excise if needed, if the tumor recurs. No radiotherapy, even if it appears to be locally aggressive. And, you know, in some cases, if it is an incidental find, well, not incidental, if it is found at mammography, for example, a stellate lesion, is this an invasive carcinoma or a fibromatosis? If we are sure it's fibromatosis, and it's such a small lesion and doesn't give any problem to the patient, they don't take it out. They watch it. Sometimes it can be used, you know, the different drugs have been used, including Gleevec for aggressive fibromatosis. And maybe I have another, you want me to show another case? This is another case mentioned before. I don't have a clinical history for this, but I know this case. Elderly man, let's say 69-year-old, not too elderly, but with a big mass in the breast. So it's another, I don't have the, you know, good breast parenchyma in this case. Oops. Here is a kind of a typical morphology, right? We are talking about bland spindle cells today. What do you think about this one? We have, you know, nice spindle cells in between collagenous fibers, yes, very thick. In the US, they say ropey, meaning like a big rope, a thick, una corda, una fune di fibre collagene. Ropey fibers and, you know, these short fascicles, kind of haphazardly arranged. Here is another one, Noah tipia. The nuclear features still look benign. There are some intranuclear inclusions, right? What could this one be? Sorry? A mastocyte, a mast cell. Yeah, I tried to find it. It's not, I'm not 100% sure it's a mast cell, but it should be a mast cell in this location, right? With the scanning, it was not so easy to find one. I think I even found, this looks more like plasma cell, but in any case, maybe I was referring to this one. In any case, there should be mast cells in this case. It's an interesting case because it has also some more hypocellular areas. It's a very large tumor. And it has this, how would you describe these changes in the vessel wall? It looks like fibrinous, you know, fibrinoid necrosis or something like that. Does that qualify? It was quite conspicuous in this case. Some areas are less cellular and alternate with more cellular areas like here. So what would be your, what would you do? Seek it. Cytokeratin. How about CD34? Also, right? So I don't know what I have for this case, probably nothing. This is the excision. I can tell you, I think it was a CD34 positive. ER might be, was, I don't know if it was positive or done, but it could be positive. Desmin, I think, could have some positivity, but it's not definitive. And then ALK, I have no ALK for this. Why, what would be your differential? But it's not too inflamed, right? This doesn't look too inflamed. The previous case looked more inflamed to me. This is a circumscribed mass. No, I don't think there is any breast parenchyma entrapped in it. And it has these spindle cell fascicles, the ropey collagen. I think in this area, a lot of murmuring here. What palisading, beautiful palisading. Is it a schwannoma? No, right? But this area looks like a verrucate body in a schwannoma. This is a myofibroblastoma, a huge one, and can occur in males and females, median age 50 years, circumscribed, slow growing, painless. Adipocytes are part of these lesions, right? Usually there is no gland or epithelium in this lesion, and it has this molecular alteration, partial monosomy of 13q and 16q with deletion of chromosome 13q14 in over 50% of cases, with the results in the loss of RB1 and the FOXO1 gene. So these tumors are RB1 negative. We do that sometimes to, confirm the diagnosis. Again, a negative stain never confirms anything, but it's consistent. Here is the ropey collagen fibers I mentioned before, and the bland spindle cells. They arrange in straight bundles, and then there are intranuclear inclusion, many mast cells of these, I'm sure. And, sometimes can have palisading in the differential diagnosis with schwannoma. Actually, the case I just showed you is much better palisading than this one. And CD34 is usually diffusely positive. Sometimes can have myxoid change, another one. Sometimes the dangerous one is the epithelioid myofibroblastoma, because this tumor can be ER and PR positive. And this case actually was given to me by this image by a colleague who had called the case invasive lobular carcinoma on core biopsy, because this is the case. It looks like it could be a poorly preserved invasive lobular carcinoma. He did ER and PR, they were positive, right? Except that when the tumor was excised, it was nicely circumscribed, which never happens with an invasive lobular. So then he started to do other things, including cytokeratin, and it was negative. And here, sometimes it's very lipomatous, and this could be in the differential with fibromatosis, because the spindling looking cells. But I must say, I have seen a case, and I think I have images of this, that was called fibromatosis-like metaplastic spindle cell carcinoma in a core. And this is the case. This was a lipomatous myofibroblastoma, so a lot of fat with just focal areas of spindle cells that appear to infiltrate the fat in a core biopsy. And the outside pathologist had done ER and PR, and they were both positive. So he thought, well, it's spindle cell and it's ER, PR positive. It must be a fibromatosis-like spindle cell. Low grade, it must be a low grade fibromatosis-like spindle cell carcinoma, metaplastic of the breast. And this is kind of amazing. Again, another example of how you go along the wrong path if you try to fit your findings, objective findings, to your diagnosis. look at the data and interpret it in context. Metaplastic carcinomas are typically triple negative. They will never be these ER and PR positive. And think about something else, you know, do a keratin, like that would have been helpful. Keratin will help in the different, you know, to confirm it's at least a carcinoma. And these are always negative for keratin, for vascular markers, low Ki-67, a very benign tumor. CD34 is positive. Desmin can show focal positivity as well as SMA, muscle actin, and CD10. ER and PR, that's the danger of these tumors when they look epithelioid or, you know, have this infiltrative look. And then, you know, sometimes can some positivity for calponin S100 has been reported. And I'm going to stop here. Is that the time, right? Thank you. Thank you very much.